شايفين؟
clear, very clear.
اوكي. بس بدي Am I clear now? خالد شايفين؟
ايوه دكتور.
طيب لما بدكم نبلش قولوا لي.
يلا بلش دكتور خلاص.
اوكي. اليوم today we are going to discuss cerebral palsy, myelomeningocele, Duchenne muscular dystrophy, Becker's muscular dystrophy, spinal muscular dystrophy, etc. All these will be discussed and presented today. Of these, the most common in Lebanon, in our country, we have cerebral palsy and myelomeningocele, but the rest will be discussed as part of the completion of this course. The disorders arise from a wide range of etiologies. They can be congenital, developmental, genetic, chromosomal, or acquired disorders. At the level of the brain, the spine, the peripheral nervous system, or muscle. Although basic science and epidemiologic research continues to evolve in understanding of these conditions will possibly lead to prevention or cure. Orthopedic surgery plays an important role in the management of children with these disorders within the context of a multidisciplinary approach involving numerous healthcare disciplines. We will be discussing cerebral palsy. Cerebral palsy is not only resulting from congenital or problems that have occurred within the fetus. Any situation before the age of 2 years with disturbance or injury of a portion of the brain could lead to cerebral palsy. So keep this in mind. It's not a congenital condition. It's not obtained by inheritance. What about the definitions, etiology, and the pathophysiology? Cerebral palsy, which I will be referring to as CP, comprises a heterogeneous group of disorders of the development of movement and posture, which arise from permanent but non-progressive disturbances in the developing brain of the fetus or infant. It's not a progressive disorder. If one has involvement of a diplegic variety or monoplegic, it does not mean that he will progress to a paraplegic or quadriplegic. It's a non-progressive condition. It can affect certain portions of the brain. If it involves in the cortex and there is damage of the cortex, these children will be born as spastics. And this is the most common type. If it arises in the basal ganglia, meaning that the injury occurred in the basal ganglia, or the disturbance, they become dyskinetic. And if it involves the cerebellum, they will be ataxic. They have a typical ataxic gait. Or you can have mixed types. A number of children with cerebral palsy will have two motor types present. Yeah, dyskinetic combined with spastic, or dyskinetic combined with ataxic. This represents the mixed types. The motor, the problem, Honey, I don't know how I'm going to get rid of this. Wait, let me see. If I can get rid of this, I cannot. The motor disorders are often accompanied by disturbances in sensation, perception, cognition, communication, and behavior. They can have epilepsy and secondary musculoskeletal problems due to the difference between, let's say, spastic muscles and normal or weak muscles. Collectively, CP is the most common cause of chronic disability in children, with a prevalence of 2 to 3 instances per 1,000 live births. The etiology of CP is diverse, with most cases being related to prenatal and neonatal causes, such as premature birth. This is the most common risk factor. The premature brain is particularly vulnerable because of its fragile vasculature and the immature autonomic nervous system that regulates cerebral blood flow. What are the risk factors for CP? Prematurity, as we just mentioned. When they're premature, they are of low birth weight. These are predisposed. In women who have multiple births, the incidence of the child in the last delivery periods is a risk for cerebral palsy. Infections like toxoplasmosis, syphilis, rubella, cytomegalic virus, and herpes simplex or diseases. Chorioamnionitis, placental complications, third trimester bleeding, maternal epilepsy, toxemia, low APGAR scores, anoxia, intraventricular hemorrhage, infection, etc. Preventricular leukomalacia, meaning that a brain injury, most common in babies born too soon, premature, is the most common lesion associated with prematurity. This is part of some questions we ask. Which is the most common cause? It is a periventricular leukomalacia, an intrafetal brain injury, which is premature. He's born premature. It is the most common, and you have to keep this in mind. Other prenatal causes include intrauterine infections, as I mentioned, and all these types of infections that I spoke about. Congenital cerebral malformations such as encephalopathies, segmental defects, microcephaly, and cortical dysgenesis account for approximately 15% of all CP cases. Hypoxic encephalopathy at birth in full-term infants accounts for only 10% of the cases. Postnatal causes: hyperbilirubinemia, metabolic abnormalities, postnatal trauma, shaken baby syndrome, infections, and toxicity. Enough for causes. But it's nice and important that you remember that it is a non-progressive condition. You cannot compare it to Charcot-Marie-Tooth disease because Charcot-Marie-Tooth disease is progressive. Friedreich's ataxia is progressive. Acute myelogenous forms of infections of the brain can be progressive. So keep this in mind. The primary disturbances in the brain results in an upper motor neuron disorder that is associated with abnormal muscle tone, most often hypertonia spasm, and is accompanied by a loss of selective motor control, muscle weakness, impaired balance, and a delay in the development of motor milestones. Motor disorders contribute to secondary musculoskeletal problems, including muscle contractures, because muscles around the joint are not equally affected. So it is a disturbance between two forms of muscles, one which is spastic and one which is not. And therefore, this could lead or would lead to deformities with time, shortening of muscles, lengthening of muscles, and loss of function. Muscles grow in response to stretch that occurs from typical physical activities associated with normal motor developmental milestones, such as rolling over, sitting, crawling, pulling up to stand, walking, running, and jumping. So this also affects the growth, the normal growth. If you have a monoplegic form of CP, due to the spasm, you'll have disturbances on it. I would like to ask who is scribbling on the screen, Khalid? في حدا أحمد الحج is scribbling on the screen. And actually, this is bothering me as I'm giving the lecture. In patients with cerebral palsy, the abnormal muscle tone initially results in dynamic contractions where the muscle is taut because of hypertonia, but of normal length. As motor development is delayed, it fails to progress. Muscle growth fails to keep pace with the skeletal growth. So tight muscles gradually become short relative to the length of the bones. That they may traverse. If you look at this patient is a spastic, monoplegic, or diplegic, because it seems to be more severe on one side than the other. You can notice from this photograph, you see that the extremity on the left side is shorter than that on the right side. Why? Because there is a disturbance in growth secondary to the muscle imbalance. Of course, they have spasticity, and this child is a toe walker. Dynamic contractions become more fixed or static. Delayed developmental milestones and the forces associated with contractions result in altered development of the growing skeleton. So, as I have repeatedly mentioned, that with time they have a muscle imbalance. The muscle imbalance causes deformities in the joints with time. And of course, in a growing child, it will delay the growth on that side so that you will get a leg length discrepancy in these children. Another important point, infantile morphology in these patients is disturbed. They have femoral anteversion. The bones fail to remodel naturally and results in secondary bony deformities and joint instability that contribute to lever-arm dysfunction, which in turn affects the quality and the efficiency of gait and other aspects of physical function in children who are ambulatory, or results in deformities of the trunk and limbs that can affect the health-related quality of life of those who are non-ambulatory. If you look at this child's photo, you see that this patient has flexion of the hips, flexions of the knee, dorsiflexion of the ankles. The child walks with both knees flexed, and he has a particular type of gait, which is the crouched gait. You have to keep this in mind. This occurs quite often in paraplegics who are able to walk or diplegics. What about the classification? CP has been classified based on predominant type of tone and movement disorders by anatomic distribution, whether hemiplegia, diplegia, or quadriplegia, and by severity of the motor disability according to the gross motor functional classification system. This is referred to as the GMFCS, which stands for the Gross Motor Functional Classification System. This is the first classification. It can be monoplegic, can be hemiplegic, which is the dark pink, can be diplegic, or quadriplegic. You have to keep this in mind. So you can also classify CP according to spasticity, dystonic, acetoid, ataxic, or mixed movement types. These are the ancient classification. This is what we used to classify them in the past. The most modern classification is the gross motor functional classification, or to shorten it, the GMFCS system. The gross motor functional classification system is a 5-level ordinal rating system that has become the international standard for categorizing individuals based on severity of their motor disability. The following definitions are for children age 6 to 12 years. This is the classification used, and I will go through each one individually. Children who walk indoors and outdoors and climb stairs without limitation. These children perform gross motor skills, including running and jumping, but the speed, the balance, and coordination are impaired. This is one type of GFMCS. The two type. Children walk indoors and outdoors and climb stairs, holding onto a railing, but experience limitations of walking on uneven surfaces and inclines and walking in crowds or confined spaces. Class 3 GMFCS, level 3, children walk indoors or outdoors on a level surface with an assistive mobility device, such as crutches or a wheelchair. Children may climb stairs holding on a railing. Children may propel a wheelchair manually or are transported when traveling for long distances or outdoors on uneven terrains. Level 4, children may continue to walk for short distances on a walker or rely more on a wheeled mobility at home and school and in the community. 5, physical impairment restricts voluntary control of movement and the ability to maintain anti-gravity head and trunk postures. All areas of motor function are limited in the level 5 GMFCS. Children have no means of independent mobility and are transported. 5-level GMFCS has been shown to be stable and prognostically useful and is the current gold standard method for classifying cerebral palsy. Now, speaking about the classification according to anatomic zones of weakness, you can have quadriplegia where you have involvement of the forelimbs, you have the whole body, forelimbs and bulbar problems, and difficulty in swallowing is part of the classification. You can have hemiplegia, one side of the body, and diplegia, the lower extremities, but can have some upper extremity posturing. So don't forget this classification. Please don't forget it. What about the natural history? This is very important. Motor function improves in all children with cerebral palsy leveling off between 6 and 7 years of age. Functional levels typically remain stable until early adolescence. During adolescence, many ambulatory children will experience some decline in function associated with worsening of musculoskeletal pathology that accompanies the adolescent growth spurt and is compounded by an increase in their body weight. Many of these children are overweight, and this lets them function poorly. So you have to keep this in mind. Understanding the natural history is critical to put in context the perceived or rare benefits of any treatments that these children receive. Improvements after treatment in a younger child must be greater than the expected improvements in gross motor function that occur naturally prior to age 7 years. Interventions in older children who show little change in outcomes might still be effective in preventing functional deterioration associated with growth. The true benefits of different treatments can be inferred only from studies that include natural history controls for comparison. Longer-term studies are needed because the growing child is at risk for recurrent deformity and deteriorating function over time. Treatment. First of all, when we get such a patient, the very first what we do, we evaluate that child. We see where the problem is. Is it monoplegic, quadriplegic, etc.? Then we evaluate which type. Does this patient have ataxia, his gait? Does this patient have epilepsy? We go into the history of each. Then we go through a trial of physiotherapy, and it addresses the development of gait and functional mobility with gait trainers. You have special gait trainers who train their candidates on computerized gait function or movements with the use of walkers or crutches and prevention of contraction through stretching, bracing, and standing programs. Occupational therapy. We teach the child how to eat, what to use, whatever available for him to make use of. This addresses fine motor function, activities of daily living, self-feeding, self-dressing, and communication through speech or adaptive equipment. We don't forget about this child. This child can be functional, he can be producible, and one should respect this. There are children who have a slurred speech. You have to give them speech therapy. This is often a requisite, particularly in children with significant bulbar involvement, with difficulty of swallowing, splinting, or serial casting may prevent or improve spasticity and contraction. Bracing is often used to improve joint or limb position in stance or ambulation, or to prevent deformity. Supramalleolar orthosis, SMOs, supramalleolar orthosis, may be used to control plane deformities of the foot and ankle, pronation or supination, but do not address the sagittal plane, equinus, or calcaneus. What about the ankle-foot orthosis? This may be used to stabilize the ankle joint. A solid ankle-foot orthosis may be used to prevent equinus or a crouched stance due to uncontrolled dorsiflexion of the ankle. If they are in marked dorsiflexion, this promotes or stimulates a crouch gait in association with knee flexion and hip flexion. Prevention of equinus and calcaneus has been shown to improve walking speed and stride length for most children. A hinged ankle-foot orthosis may be used to allow dorsiflexion while preventing equinus during gait. Floor reaction, ankle-foot orthosis cause knee extension to improve and crouch gait secondary to ankle plantar flexion weakness. Knee ankle foot orthosis stabilizes the knee and are useful for maintaining knee position in children who walk very limited distances or only stand. I would like to stress at this point is that you should be well acquainted with the braces used in cerebral palsy. You should be acquainted with the knee ankle foot orthosis. You should be acquainted with braces that prevent extreme of dorsiflexion of the ankle. You should be acquainted well with the equinus braces, which is due to weakness of plantar flexion. This will help stimulate knee extension when you put this brace on. Knee ankle foot orthosis stabilize the knee and are useful for maintaining knee position in children who walk every limited distances or very limited distances or only stand. At this point, I would like to mention we in the United States and Canada provide special courses on these braces. In addition, we give special courses on computerized gait analysis and encouragement of a child to walk while the evaluation is being done on his whole condition while walking and using computerized gait analysis. What are the anti-spasticity medicines? Oral administration is common, but dosage needs to be adjusted if relaxation is accompanied by an unacceptable amount of sedation. And this is known as baclofen. خالد عم بتعذب، عم بيطلع على السكرين الأسود كله، يعني ما عم بقشع السلايدز تبعولي.
دكتور جون عندنا ما بيظهر الاسود، يعني يمكن ما ادري.
بعرف بس انا عم بتعذب من هيك ليه I'm having to stop to move around the pointer to get it out of the way. You see, one of the drugs that we use as antispasmodics is baclofen. But the problem is it requires large doses when given orally, and it is not without side effects. It needs to be adjusted if relaxation is accompanied by an unacceptable amount of sedation. Intrathecal baclofen is administered by an intrathecal pump as shown in this slide. And this is associated with less sedation. We don't have to give patients Valium with the medication has to become effective. This consists of a pump and a catheter that relaxes the muscles through the nerves from L1 to S1 when this pumps into the canal, into the cerebral spinal fluid, and the response is good, and it's less toxic than giving baclofen by mouth. Now, we like to give this quite often, and we give it whenever we fail to have a response when we give it orally. And it is indicated in moderate to severe spasticity and with a component of dystonia. This is how we give it. We give it intracecally, targeted delivery of the drug directly into the cerebral spinal fluid, as I mentioned. And it is very effective from L1 to S1. In other words, it is more effective than when we give it orally. We have quite a few problems when we try to give baclofen orally. This is a gross appearance of the pump with the catheter placed intracecally. All oral baclofen is poorly absorbed, and the large doses required for any significant clinical effect are associated with undesirable side effects. Intrathecal administration of baclofen with an implantable pump allows for very small doses and micrograms to directly reach the targeted tissue and is an effective way to control severe generalized hypertonia, but it is usually reserved for children with severe symptoms such as GMCS level 5, because it is expensive and can be associated with several complications. Valium is administered orally, but it also can result in significant sedation before sufficient muscle relaxation is obtained. Fixed contractures, bony deformities are best treated with musculotendinous lengthening or tendon transfers and corrective osteotomies using the strategy of a single event multi-level surgery. We like to do all procedures at the same time. We don't like to do one procedure every 6 months. This affects the child. This affects the development of the child. So we like to do them all at once. What about surgical spasticity management? This is what concerns you orthopedic surgeons. One of the procedures that we are doing quite often is selective dorsal rhizotomy, SDR. It reduces spasticity by selectively cutting dorsal nerve rootlets between L1 and S1. SDR, or selective dorsal rhizotomy, may be indicated in ambulatory patients with diplegia, and the ages are between 3 to 8 years with good selective motor control and intelligence in the normal range. Fewer than 50% of the rootlets should be cut at any given level. one should be precautious because it can increase the risk of spine and hip deformities and may increase weakness as the child reaches adolescence. This is a diagram showing of how we do it. You can see on the right-hand side, you can see how the rootlets are being divided, and we selectively divide 50%. You have to keep in mind that you can occasionally do harm. You can overdo it by resecting more than what is required. Selective dorsal rhizotomy, followed by physiotherapy, when compared with physiotherapy alone, has been effective in reducing spasticity in the lower extremities of children aged 4 to 8 years with spastic cerebral palsy. But this reduction in spasticity was associated with a modest improvement in gross motor function. Selective dorsal rhizotomy may not reduce the need for subsequent orthopedic surgery, and evidence regarding long-term benefits is sparse. Baclofen, which another name is given, contains aminobutyric acid agonist, can reduce generalized spasticity. We mentioned about the intracecal baclofen. This is a gross section showing the rootlets of how they are selected and divided while doing selective dorsal rhizotomies. Coming to buttocks, botulinum toxin affects the neuromuscular junction. Why? By it prevents or blocks the presynaptic release of acetylcholine. Botox A is the form commonly used in the United States for children with CPs. In CP, intramuscular Botox or botulinum toxin injection results in 3 to 6 months relaxation of spastic muscles. It is commonly used in conjunction with physiotherapy, stretching, casting, or bracing. It will release or relax the spastic muscle while you're working on the weaker muscles to build them up to oppose the spastic muscle. So it's useful not only for dynamic spasticity only, but also when you get fixed contractions with no joint changes, it will relax the spasticity around that muscle and let you work on that joint. It may be considered as a temporizing measure to delay surgery. Keep these points in mind. This shows you how to inject the Botox. You go directly in the muscle, you inject it. And this is the response. They have partial recovery in muscles and in 12 months. So you have to realize that to inject Botox, you can help in the buildup of muscles. Optimizing gait function improvement of gait appearance are the main goals of treatment of ambulatory children with cerebral palsy. Better gait should be associated with an increase in speed and endurance, improved balance, fewer falls, reduced reliance on walking aids, reduced fatigue, and pain relief. Now, I'd like to mention that if you don't have botulinum, if you don't have Botox available, what we have been doing at our institution, occasionally we inject phenol, and we're getting a temporary relaxation of spastic muscles. So phenol is available in all pharmacies or laboratories, and you can obtain it easily. Now coming to computerized gait analysis. It's all done on the computer, and you can evaluate the patient's functional demands, which are lacking secondary to spasticity. It helps and improves gait. These are the various types of how we put these computers on, and we record, and we're able even to judge the results of surgery. Non-ambulatory children with cerebral palsy, GMFCS levels 4 and 5, often experience several comorbidities, seizures, cognitive, visual, and hearing impairments, communication difficulties, swallowing difficulties, drooling, aspiration, gastroesophageal, reflux, constipation, and incontinence. These are all, they require continuous nursing care. Many of these children are at risk for aspiration, pneumonias, malnutrition, requiring insertion of gastrostomy and gastrojejunostomy tubes for safe feeding. They can also develop contractures of the upper and lower limbs, progressive hip displacement, and scoliosis, which can be associated with pain and difficulties with positioning, seating, and caregiving. These children rely on caregivers for much of their activities of daily living. The goals of treatment for non-ambulatory children include prevention or relief of pain, facilitation of caregiving, and preservation or improvement of health and quality of life. What is the treatment strategies for ambulatory cerebral palsy? Botox, we spoke, injections are effective in reducing calf muscle spasticity. And I'm sorry, if you look at the slide below, this was what I was trying to tell you about the previous slide, which was very similar to it, but for a different purpose. In the slide, in A, you see you have a spastic gastrosoleus muscle. The Botox is being infiltrated, and they go into neutral position. They are less spastic. They become plantigrade. And then after a certain period of 6 months or more, the spasticity recurs. During this period, you can give physiotherapy to build up the weaker muscles, to overcome some of the spasm that is present from gastrosoleus muscle spasticity. Okay, so keep this in mind. They are effective in reducing calf muscle spasticity and increasing ankle dorsiflexion in short term, but are not superior to serial casting. Contradictory evidence exists regarding the effectiveness of combining buttocks A with serial casting. Coming to surgical patients who are ambulatory, selective dorsal rhizotomy followed by physiotherapy, when compared with physiotherapy alone, has been effective in reducing the spasticity in the lower extremities of children 4 to 8 years with spastic cerebral palsy. So this, I repeat repeatedly, don't think selective dorsal rhizotomy is the solution. At times, as we are resecting 50% of the rootlets, we can occasionally harm the patient. We can make muscles more weaker than what we were expecting, and we can lead to deformities. So one should be very, very careful as he decides to do selective dorsal rhizotomy. But the advantage is you can compare it, you can add it to physiotherapy. You can do the two together, and you can end up having good results if well done. In non-ambulatory cerebral palsy, physical therapies, stretching, strengthening, orthotics, serial casting are early treatment strategies for some of the musculoskeletal consequences of cerebral palsy. Dynamic contractions, secondary to increased muscle tone, are treated with targeted injection of botulinum, as I showed you, or phenol into the specific muscles, or more systemically by neurosurgical methods such as selective dorsal rhizotomy and intrathecal baclofen. These are believed to prevent or delay the onset of static contractions, which we don't like, meaning that there are joint changes, stiffness, and really difficult to correct, even with casting. And these are the the contractions that will end up having surgery. The current evidence for effectiveness of these interventions for children with ambulatory cerebral palsy is well summarized in systematic reviews on the subject. Botulinum toxin A injections are effective in reducing calf muscle spasticity, as I've spoken repeatedly. And they are used very frequently, but not to expect a perfect result without serial casting. Limited evidence exists that the reduction in spasticity brought on by buttocks potentiates the effect of physical therapy interventions to reduce hypertonicity, and these interventions result in measurable functional benefits. The long-term effects on benefits of buttocks still remain unknown. Fixed contractures and bony deformities are best treated with musculotendinous lengthening. This is where surgery comes in, and tendon transfers and corrective osteotomies using the strategy of single event multi-level surgery, doing them all at the same time compared with staged single-level procedures. There are few published studies of durability of outcomes or the long-term effects of multi-level orthopedic surgery. What about hip instability? Treatment for neuromuscular hip subluxation can be divided into proactive and reactive strategies. Proactive strategies aim to slow the progression of subluxation and prevent dislocation. The goals are to prevent pain and progressive limitations in perennial care. I'll tell you, many times I have had patients coming to me with cerebral palsy with a scissoring position of the extremities. You could not widen the hips apart to do the perennial care. For this reason, we have to consider all sorts of treatment to allow perennial care to be given. And of course, to relieve these children of pain if they have. Prevention strategies, coupling radiographic surveillance with proactive surgical treatment can nearly eliminate hip dislocations in patients with cerebral palsy. And what I mean here is that you have to follow your patients well. Not only performing surgery, because these tend to recur due to the muscle imbalance. You have to keep your eyes open. And what to do is very important, whether to increase the depth of the acetabulum by promoting a further coverage of the head or by decreasing the muscle imbalance that exists around the hip. What was found was by the Swedish people, where they did a long-term study over a 20-year period, and they found that they hardly had any problems with the hip over that period if they followed up their children well. Beginning at the age of 2 years, the hips of children with cerebral palsy should be monitored with annual pelvic radiography up to the age of 5 years in ambulatory patients. Levels 1 through 3, GMFCS, and up to skeletal maturity in non-ambulatory patients for level 4 and 5. They need a continuous follow-up by radiography, by physical examinations, by prevention. And what I mean by prevention, balancing the spastic with the non-spastic muscles. Monitoring may be discontinued at these endpoints if the hip is normal. Look at the joint. If the hip is uncovered, you have to continuously follow up this patient. If there's a continuous muscle spasm, you have to keep it in mind that this can re-dislocate. If subluxation is present, the Raymer migration index is used, which I will discuss soon, is used to measure the progression of subluxation. When the Raymer migration index exceeds the 50% threshold, hip reconstruction is recommended. This is how we measure the Raymer. You have P as a line drawn through the upper outer margin of the acetabulum. This is P. You have Helgen-Reines line, which is H. And you have a line drawn vertically perpendicular to Helgen-Reines line at the outer margin of the head. And you have another line drawn from the inner margin of the head, again perpendicular to Helgen-Reines line. If the distance A over B is more than 50%, surgery should be considered very seriously. Two osseous components, coxa valga and acetabular dysplasia, contribute to the neuromuscular hip subluxation. The femur is characterized by persistence of immature hip morphology. Namely, they have coxa valga and femoral anteversion. Delay in walking prevents normal pressure relationship between the femoral head and the acetabulum. Without early weight bearing and in the setting of muscle spasticity, especially spasticity of the adductor and flexor muscles, and weakness of the hip extensors and abductor muscles, the neck shaft angle and anteversion of the femur remain increased. You have to have a proper balance so that anteversion and acetabular development should occur normally. There is no stimulus to cover the femoral head with a deep acetabulum. When you have coxa valga anteversion present, the child is not walking, this will not stimulate the acetabulum to develop normally. Please keep this in mind. In the femur, coxa valga and excess anteversion can be treated with proximal varus derotation osteotomy. The goal is to maximize coverage of the femoral head at the time of surgery. The amount of varus depends on the child's preoperative ambulatory status and the potential for future ambulation. Hip coverage can be improved by increasing the degree of varus. But I like to warn, many surgeons around me do varus osteotomies. Don't allow varus to be more than 110 to 115 degrees. Meaning less than 110 to 115. Why? Because what will happen? You are shortening the abductors and you are impairing post-operative gait. It should be around 115 to 120 degrees. Then you say you've done a proper varus derotation osteotomy. Acetabular dysplasia in CP is characterized by superior and posterior insufficiency of the acetabulum. Therefore, incomplete osteotomies, whether Pemberton, Dega, San Diego, and incomplete periacetabular osteotomies are recommended over a complete innominate osteotomy, like Salter. You see the problem with Salter, you cover the head anteriorly and laterally, but you uncover it posteriorly. The Pemberton and Dega osteotomies provide more anterior coverage and are not recommended for patients of level 4 and 5 GMFS who have posterior acetabular insufficiency also. So keep this in mind. Okay, they provide anterior coverage, they uncover the hip from behind. These are the three, the Dega, the Pemberton, but the Salter more commonly. Maximizing coverage of the femoral head during hip reconstruction is important because the muscle imbalance that preceded the reconstruction will persist after the reconstruction. Unlike in developmental dysplasia of hip, redirecting the femoral head toward the triradiate cartilage in neuromuscular hip subluxation does not reliably stimulate acetabular remodeling around the femoral head and continued growth. So you have two differences in typical dysplastic hips. If you do a varus osteotomy and you derotate that head, the stimulus on the triradiate cartilage, if done at an early age, will promote remodeling of the acetabulum. While in CP or cerebral palsy, this does not occur. Please keep this in mind. You have to compare this with this. You cannot treat a cerebral palsy with a dysplastic hip as though you were treating a normal congenital dysplastic or developmental dysplasia. You have to distinguish the two. The risk of redislocation is proportional to the potential growth remaining and disease severity. A retrospective study of 144 hips in 25 patients showed that progressive subluxation after hip reconstruction does not occur in levels 2 and 3 GMFCS, but does occur in levels of 4 and 5. So keep this in mind, the level of the palsy. First of all, you have to evaluate your patient. You should know what level that patient stands for in accordance with the GMFCS classification. If it's level 4 and 5, you should be aware. مش بس إنه رجعنا الهب لمحله, it's not going to redislocate. At these levels, statistic-wise, long-term reviews have shown that it could recur in these levels. Why? Due to the continuous muscle imbalance in these cases. While in levels 2 and 3, it's much less to recur. I hope I'm clear at this stage. If a hip dislocates, the decision for hip reconstruction or salvage should take into consideration the patient's ambulatory status and the level of pain. Believe me, I have seen children having a lot of pain, especially those that were stage 2 and 5, as well as radiographic characteristics of the hip. A hip that remains subluxated will have progressive wear from the capsule and spastic abductor muscles. Because obvious wear can generate pain, reducing an arthritic femoral head into the acetabulum may be ill-advised. Yani, what I'm trying to tell you, if you have treated the patient's hip, you got a good reduction. Then after 1 to 2 years, you see that the hip has redislocated. You should make sure that that hip is still in condition, because if you operate and you relocate that hip and the cartilage is gone, then you are provoking more pain to this child. In this case, salvage surgery is an option. Techniques include proximal femoral resection, and this is called the Castle procedure. I repeat, this is called the Castle procedure. I love this question. When we resect the proximal femoral head with the neck, or we call it or you can do without resection, do a Shan's procedure, which is a proximal femoral valgus osteotomy, with or without resection of the femoral head or neck. This is a patient that has had a resection of the femoral head. This patient had pain in the hip. One could not reduce this head. It was partially destroyed. So a Castle procedure was done. In C, you see the head up to the base of the neck was resected. In addition, a valgus osteotomy was done to the resected portion, which is B, and the patient was relieved of pain. The Castle procedure was originally described with a required period of 3 months of post-operative traction. كنا نشيل الهيد مع النك ونحط البيشنت in traction. A recent study reported improved success rates without post-operative traction. A 2014 systematic review of salvage surgeries for painful dislocated hips in patients with cerebral palsy found that each technique had a success rate. Complications included persistent pain. There were some patients who had heterotopic ossification, and one of our weakest points was that some patients had had skin ulceration. Lower extremity surgery in ambulatory children. The surgical treatment of gait abnormalities in children with cerebral palsy involves addressing contractures that prevent joint range of motion at various levels, the hip, knee, and ankle, as well as realigning the rotation of the long bones. These procedures are done to improve kinetics and gait efficiency. The decision for or against surgical treatment depends on the nature of the patient's disability and the potential for successful rehabilitation. Children with cerebral palsy may have neurologic manifestations such as dystonia, ataxia, chorioacetosis that limit gait and will not be improved by surgery. You have to keep this in mind. Evaluate your patient. Make sure he doesn't have dystonia, ataxia, or chorioacetosis that limit gait. Because these patients, if you operate on, you're wasting their time. You are bothering them. You are lowering their level of training by doing surgery, because they won't improve with surgery. There may be an underlying weakness that prevents ambulation, or behavioral or cognitive limitations that prevent participation in preoperative and for postoperative therapy. These limitations can result in failed improvement in joint contractures or in malrotation. That is, when you have these, they won't allow improvement. Inappropriate or excessive lengthening of tendons. مش كل مريض عنده شوية spasm تيجوا تطولوا له, you lengthen the tendons. I would stress one important point. You should not over lengthen tendons, because you will be doing more harm than benefit. This can decrease the patient's motor strength, and the surgeon should always consider the risk of an ambulatory child becoming non-ambulatory after a major orthopedic intervention. فإذا ما تفكروا إنه عم تعملوا surgery for the benefit of the patient, because there are many children where your indications were poorly done, where you harm the patient, and instead of the patient improving, he becomes worse. So you have to really know how to choose your patients. And actually, to choose your patient and to choose him properly, you should work as a multidisciplinary group. There should be a cerebral palsy clinic in all respectable institutions. You should learn to work together and to give and provide the patient with the maximum benefit of treatment and surgery. So, quantitative, three-dimensional gait analysis provides substantial research benefits and serves as a clinical tool to analyze relationships among forces, center of mass, ground reaction force, kinetics, joint motion, video-based kinematics, and muscle activity, and electromyography during each movement of the gait cycle. بدنا نسكرها يا الله. عم بيطلع لي شيء علي. I'm really bothered by it. يلا. So, quantitative data can be combined with observational and video-based analysis, physical examination findings to accurately diagnose gait pathology and develop a surgical plan. Because spasticity is eliminated by anesthesia, examination under anesthesia is the most useful method for determining through mechanical limitations of range of motion. Sorry, I want to answer the phone. Hello. أهلا أهلا. رامي لك حولي لي يلا حولي لي بس يعجل بالحكي اللي أنا عم بعطي محاضرة لليمن. الله خليك. Sorry, Khalid. Just give me 2 minutes. الو. ايه رامي، سوري ما رح تقدر تطول معي.
دكتور جون الصوت ما فيش صوت. دكتور جون برضه الصوت ميوت. دكتور جون ما فيش صوت.
سامعيني هلا؟ سامعيني يا خي؟ شلتوا لي الصوت، صار لي ساعة عيط وصرخ ما في صوت.
اوكي اسف دكتور، الان الصوت رجع دكتور واضح.
حبستوني برا. رجعنا للمحل ذاته.
ايوه رجعنا.
خالد ما كنت تجاوب على التليفون، هلكتني.
ما انا كنت اصلي والله، العفو، انا اخذت فرصه.
هيدي مسجل لك اياها
ودعيت لك يا دكتور جون.
طيب. The goal of surgery in ambulatory patients with cerebral palsy is to eliminate joint contractions, rotational abnormalities that affect. ما عم بسمع يا جماعة، ما عم بسمع.
خلاص دكتور كمل دكتور.
كمل أو لا؟ ما بدكم كمل؟
لا
نلغيها؟
كمل.
Rotational abnormalities that affect gait, biomechanics, and impair function. Focusing on priorities of gait allows the surgeon to define the impairment and determine the potential benefit of surgery. For example, the first priority of gait. Stability in stance is vital to gait. All this is analyzed by the process of computer gait analysis, which is tridimensional. And this helps us to tell us which are the weak points in not allowing the proper gait. We have a special room at one of our universities, mainly used for gait analysis on these cerebral palsy patients. Even it will let us judge which muscles should be injected and which muscles should be left alone. What types of surgery are being helped by this process of computerized gait analysis, CGA. Without stability on the stance limb, gait is not possible. Ataxia will manifest as instability in the stance phase, and subsequently all other priorities of gait will be affected. Because orthopedic surgery cannot change ataxia, surgery will fail to improve gait. If stability in stance is limited because of fixed equinus contraction manifesting as a small base of contact, then stability may be improved with lengthening of the gastrocnemius soleus complex. In equinus contraction results in poor clearance, toe catches at the mid-swing phase. يعني الأصبع بيدق بالأرض, and they can trip if they have an equinus deformity. Poor pure positioning caused by limited dorsiflexion at the terminal swing. Decreased stride length caused by inability to advance the center of mass over the talus during the stance phase. Poor conservation of energy caused by loss of foot rockers. All these interfere. This is what gait analysis helps us. Orthopedic surgery can reduce contractions at the hip, knee, and ankle, increase stride length during the swing phase, يعني بتزيد الفشخة. It decreases energy expenditure during the stance phase. It improves weight transition over the ankle during second rocker base phase. Bony realignment, patella tendon shortening, tendon transfers can improve the biomechanics of gait to prevent collision of the knees during gait incissoring. Yani as they're walking, you see that one thigh comes in the way of the other. By doing surgery, you can improve this, and gait will improve. You should improve the efficiency of existing strength to maximize ambulatory capacity. Fixed contractions can occur around any or all of the joints in the lower extremity. A patient's gait can be classified by influence of the contractions at each level. Over here is an illustration of gait patterns seen in patients with spastic diplegia. The arrow show the alpha angles. This is the alpha angles. In group 1, a true equinus is driven by the gastrocnemic contraction without flexion contraction at the knee or hip. In group B, you see that the angle has become more with respect to the flexion of the knee and hip. The jump gait is characterized by an equinus contraction with compensatory knee and or hip flexion contraction to clear the foot off the ground. In group 3, you have an apparent equinus. It's similar to the jump gait, but the toe walking is driven by the flexion contraction of the knee. So, in other words, the gait depends on the equinus position of the foot. It depends on the amount of flexion of the knee and hip to clear the foot off the ground. So these are the illustrations that I am trying to demonstrate, and more in detail. In group 4, you see that you have dorsiflexion of the ankle. When you have dorsiflexion of the ankle with flexion of the knee and flexion of the hip, you will have a crouch gait, which is characterized by excessive ankle dorsiflexion and contractions of the knee and hip. The equinus gait is through equinus gait, inadequate dorsiflexion through the ankle joint shift. First contact toward the forefoot. To maintain the center of mass, the knee, which does not have a fixed contraction, is kept bent through the mid-stance phase to clear the foot. When there is a fixed contraction of the gastrocnemius or soleus muscle, the patient will benefit from lengthening of the gastrocnemius and soleus complex. This may be done through various methods, whether the Vulpius, Striad, the Baker, all these techniques, I'm sure you as residents will get to see through your training. This is the Vulpius technique, where we just relax or release the fascia and we stretch. The advantage of this technique is that you can control the amount of lengthening. You will not provoke a calcaneal deformity. You just lengthen the required amount. These are the various techniques used. Children with cerebral palsy have normal hips at birth. Progressive hip displacement arises from spasticity, as we have mentioned, anteversion and coxa valga. So you have to pay attention to these points. The risk of hip instability is strongly correlated with increased severity of cerebral palsy. So you have to keep this in mind as you're performing this surgery to decide which are the patients who have the highest chance of recurrence. Now, we spoke about pain, so I would not go through it. Okay. We spoke about the hip at risk. We spoke this. All this we have come across. We have to lengthen the adductor and the psoas muscle to clear the thigh of the opposite side لحتى الواحد يقدر يغير الحفاض. These are the various osteotomies that we're doing for the hip in these patients. Okay, so, and this is a technique that we have removed the base, the head, look at how it's destroyed. We remove it at the base. We used to put them in traction. Nowadays, we're not. We're doing a proper repair of the capsule, interposing it, and we're getting away with 3 months of traction. The whole purpose of operating on the hips in these 4, 5, and 6 cases are the perennial hygiene. This is one of the problems that parents have throughout, and they keep complaining of, that we cannot change the diapers with ease. And there has been cases, as I mentioned, of heterotopic ossifications. Okay, so enough of this. This is the Rami. I think we discussed this. Now that I put the slides off, we're coming against them. And these, I just want to put an end. Okay. Now, did we discuss this? I have to see. Yeah, we spoke about this. And now we're coming to the place where we have left. The jump gait. I would like to mention something about the jump. When a fixed equinus at the ankle is coupled with a fixed flexion contraction of the knee and or the hip, the patient has a jumped gait. The ankle equinus and contractions of the knee and hip should be concurrently addressed. The three should be addressed completely. At the hip, psoas muscle lengthening should be performed at the pelvic brim, not at the insertion. ممنوع حدا يجي يقول اعطيتنا عملنا iliopsoas stenotomy at the insertion of the lesser trochanter. This is wrong. When you want to divide the iliopsoas, it should be at the pelvic brim and not at the insertion. So I think we spoke about the crouch gait sufficiently, and I think we spoke about rotational abnormalities. We spoke about all these. And what you should do, consider also in the leg, you can have external and distal external rotation, where you can correct it by a distal tibial rotational procedure, and you have valgus feet. Now, when you have external rotation, you can have an associated planovalgus foot with it. So this we have to take into consideration. I'm going to get over this. These are patients who have planovalgus feet. I'm going to go into it now and from here, because contractions of the Achilles tendon combined with contractions of the anterior and posterior tibial tendons result in equino-cavo varus feet deformity. Contractions of the Achilles tendon combined with collapse of the midfoot or contractions of the peroneal tendons lead to the equinovalgus feet. So you have to differentiate between this and this, calcaneo varus feet and valgus feet and plantigrade feet and loss of the medial arch. Secondary deformities encountered include hallux valgus, toe flexion contractions, and distal tibial valgus. Successful surgical treatment requires identifying the contributing deforming forces and defining each as dynamic or fixed. Dynamic contractions can be corrected with manipulation and spasticity management, such as with Botox injections. So keep this in mind. Okay, so we have done enough on the lower extremity and on cerebral palsy. We have given a very good description of the various classifications. You have to keep this in mind, and you have to know that cerebral palsy is not a progressive deformity. If you have a planovalgus foot and you want to correct it, you can elongate the lateral column by doing an Evans procedure. You can do a combined or partial tendon transfers by splitting the tibialis anterior. and transplanting it or translocating it more laterally, and even the posterior tibial tendon, and transfer one of the segments to the dorsum of the foot. But these should be dynamic contractions. When you have a bony fusion or a fixed bony contraction, you need to do body procedures. You need to do osteotomies. You need to do corrective osteotomies. You have to do either subtalar fusions or even triple arthrodesis. But we don't like it very much because we found that later on it leads to degenerative arthritis of the ankle joint. So you can do various procedures on the extremities to correct. In the upper extremity, there are multiple procedures, but one of the most common deformity is a pronation, flexion of the wrist with the thumb fixed in the palm. And with this, you need to do transfer of the flexor carpi ulnaris to the extensor aspect of the wrist to get a rather permanent correction. So this is it. So in summary, cerebral palsy is non-progressive disorder of movement and tone and posture caused by an injury to the brain during early development, because cerebral palsy manifests with great variability. The GMFCS classification helps to describe the functional ability of patients as they age. Surgery can aid in improving function. However, before the decision for surgical intervention is made, it is important to identify the ambulatory potential and ability of a child and whether his or her contractions are dynamic, not fixed, necessitating tendon transfer and or lengthening versus static or fixed requiring bony surgery. هي اللي حكيتها بالأخير. And this is very important. Distinguish between a fixed deformity and a dynamic deformity. If it's dynamic, you can work on the soft tissues. If it's a fixed deformity, you have to work on the bony structures. Hip surveillance, as I mentioned, is important for all patients. هيدي خدوها كعادة, and the high complication rate with spinal fusion should be noted. In the ambulatory patient, careful preoperative planning is necessary to identify gait abnormalities so that function can be improved and weakness prevented. Surgical procedures on the upper and lower extremity, I mentioned that one of the major procedures that we use are osteotomies, Evans technique, correction of hallux valgus, but not by the usual technique. We're doing arthrodesis of the metatarsophalangeal joints in these cases. When we're working on a calcaneovarus foot, we like to do calcaneal sliding osteotomies to correct the deformity if it's a fixed deformity. If it's not a fixed deformity, as proven by the Coleman block test, you should work on the tendons. So over here, يا الله في مني مبسوط اليوم من ورا السلايد. You have to also rule out anterior knee pain and cerebral palsy. And we found that this is associated with patella alta, weaker quadriceps, tight hamstrings, femoral anteversion, external tibial torsion, according to the whole list. Anyway, I'm going to get this out of the way. These are the various tendon procedures. You have to reach each procedure by itself, but you have to choose the proper indications. If you have a calcaneovarus, as I mentioned, you should do, if it's fixed deformity, you should do a calcaneal osteotomy. A soft tissue procedure will not be sufficient if the hindfoot deformity is rigid. In rigid feet, soft tissue and bone procedures are both needed. So you need to do it. In equinovalgus feet, you can do the Evans procedure. You also, in addition, we should do a gastrocnemius soleus lengthening. Why? Because when you have a tight gastrocnemius and soleus, the foot compensates by going into external rotation, and it dorsiflexes through the midfoot, and it appears as a flat foot. One of the differential points of a flat foot causes is a tight Achilles tendon. You have to pay attention to this. Okay? Of course, physiotherapy plays a good role in all the treatments, especially of these dynamic contractions. You have to consider doing a calcaneal osteotomy if you have a fixed deformity and the calcaneus is rigid, not soft. And you can do a sliding procedure, both in different directions, to correct the valgus or varus. You can do a triple arthrodesis, as I mentioned, but this would lead to degenerative arthritis at a certain period later on. We spoke about hallux valgus. This is a patient who has hallux valgus and is GFM3, let's say, and this was the varus. The best treatment is to do an arthrodesis, plus release of any of the tight, imbalanced muscles. This shows you a severe case, and likewise, you have to do an arthrodesis. Dorsal bunions also do occur. First of all, it is a deformity in which the great toe is flexed in relation to the elevated metatarsal, causing a prominence over the uncovered metatarsal head, which can be painful with shoe wear. Dorsal bunion may be iatrogenic, occurring after surgery to balance the foot. The deformation may either be caused by an overpowering of the tibialis anterior or an overpowering of the flexor hallucis longus tendon. Treatment is by osteotomies, corrective osteotomy. This is a dorsal bunion due to overpowering. You can see the prominence of the tibialis anterior, and the flexor hallucis is counter functioning opposite to the tibialis anterior. You see this bunion here. So you have to keep this in mind. The upper extremity, you have to It's very, very important so as to help the patient get around, to make use of upper extremities, to eat, to let wheelchairs run, etc. So this is the deformity that we have with a spastic cerebral palsy. You see that the forearm is in pronation. You see that the wrist is in flexion. And you see that the thumb is present in the palm. So keep this in mind. Occupational therapy is useful in early childhood for everyday living. Stretching and splinting. Botulinum toxin is useful for dynamic deformities we mentioned. Constraint-induced therapy, splinting of uninvolved upper extremity, is to encourage use of the uninvolved. You don't use the uninvolved. You splint it to prevent it from being used, so the child is forced to make use of his hemiplegic extremity or of his spastic extremity. This is becoming more and more popular. Surgical treatment is undertaken primarily for functional concerns, hygiene, and sometimes for appearance. Now, many times you get a patient who has an internal rotation deformity of the arm with various deformities of the forearm. He walks with his wrist flexed, his thumb in palm, and the fingers flexed, and the forearm in pronation, and the arm in internal rotation. Yani, this is very similar to what you get with the brachioplexus palsy. So you have to keep this in mind. You can do a muscle transfer of the pectoralis and subscapularis, or do a derotational osteotomy so as to promote external rotation. So if you have a flexion contraction of the elbow, then you have to divide the lacertus fibrosis, the biceps, the brachialis lengthening, brachioradialis, origin release. All these are surgical procedures that you should read from your textbook. You should follow them up on case by case. First of all, you have to learn how to evaluate your patient. You should stage your patient. You should know what are the contractions that are present. You should look at the gait. Does he have a crouch gait? Does he have a jump gait? You should look at this. Now, in the spine, you have another problem, which I have not talked much. Usually, these curves can be quite severe and rigid. And the problem with these children is that when they sit, the pelvis is rotated or tilted, that they can only bear weight on one side. And this leads to pressure sores. So you have to balance the sitting posture of these patients. And in the cases that you are unable to balance them, you have to do a long spinal fusion. You have to extend it probably to the pelvis, and you have to obtain a pelvis which is nearly as much as possible to a horizontal level, so as not to bear weight all the time on one side. So you have to keep this in mind. There are multiple procedures that you can have. Many children will end up having a radial head dislocation. Of course, you wait until the child becomes mature. If he still has problems with this, then you can resect the radial head. If you look at the slide below, you see that the thumb is fixed in the palm underneath the fingers. And this would hinder function. So you have to release the wrist. You have to release the fingers and the pronator from the medial epicondyle of the humerus. Of course, it weakens the wrist a bit, and finger flexion. But there is nothing better that we can do. We have to get the wrist in such a way that the child can open the fingers to make use of it. So this is showing you further the thumb of how it is present in the palm. It is caused by metacarpal adduction contracture with metacarpophalangeal flexion or extension contracture, sometimes with interphalangeal joint flexion contracture, clawing of the fingers with the wrist flexion, and metacarpophalangeal extension can be treated with flexor carpi radialis or ulnaris transfer to the extensor carpi radialis brevis. So you have to choose the procedures carefully. One of the ways I was taught as a resident how to evaluate the wrist in a cerebral palsy patient is to bring the forearm behind the back. By doing this, it would relax the tendons, and then you could evaluate which one was a fixed contraction, which is dynamic, which muscles, which tendons you have to release or lengthen. These fractures, these patients have a high incidence of insufficiency fractures because they have osteoporosis. And this is in the stages 3, 4, and 5, where they're immobile. So they develop a certain degree of osteoporosis, and they can have various types of fractures. And for this reason, they should be evaluated just as any other case of osteoporosis. They should have DEXA scans evaluating the Z scores in each case. Spinal deformities, we spoke about them. There are 3 types, actually. Type 1 is predominantly in the thoracic or thoracolumbar scoliosis, but there is no pelvic obliquity. This we don't have very many problems. In the long C-shaped curves, which is type 2, it's extending to the sacropelvic region. And type 3, you have the collapsing type, which is associated with kyphosis, mainly with no coronal plane deformity. Now, these patients have curves. They are often rigid and severe, and you have to extend the fusion to the pelvis. If you notice in the first slide, prior to surgery, the frontal view, you see that the pelvis is completely tilted. These patients would bear weight on the side which is distal, and they can end up having pressure sores. For this reason, we like to do long fusions to bring the pelvis up to level, as is shown following the surgery in this case. In the past, we used to use Lukey instrumentations with wires. Nowadays, we're using pedicle screws and performing a fusion. Now, it's true that we get the spine straight, the pelvis is at level, but you should realize one thing. When you do a long fusion, and these patients are helpless, they won't help you in being transferred. It's more work to the caregiver to look after these patients, but it has an advantage of decreasing the amount of sores, bed sores, and it improves the seated position of these children. Thoracolumbar curves tend to progress more than thoracic and lumbar curves, and the larger a curve at presentation, the more likely it is to get worse. Many spinal deformities remain flexible, allowing a child to be positioned comfortably in a wheelchair with appropriate lateral supports and back tilt to keep the child upright. External bracing sometimes is not tolerated by these children. And for this reason, we'd like to avoid using them. They also interfere with feeding by gastrostomy tubes. There is also little evidence that braces prevent progression of the deformity. Rigid curves causing discomfort and pressure-related problems may require custom seating with molded backs to accommodate and support the child in the upright position. This is a child. You see, this is a patient that we always use to demonstrate what we're talking about. If you look at this patient, he has a severe thoracolumbar scoliosis. If you look at the pelvis, you see that the pelvis is tilted. You see that he can only bear weight on one side of the pelvis. You see that this patient is predisposed to having a pressure sore. Also, what you see is in these patients, they don't breathe normally. And many times they have pneumonias, and they have complications. Their comorbid states are bad. For this reason, you have to evaluate your patient if you want to do surgery. What we're advising is to do long thoracolumbar iliac fusions. You know, meaning we do put screws through the posterior iliac crest into the pelvis, and we fuse the spine to the pelvis, to the thoracic region with correction to horizontalize or to create more a horizontal pelvis to prevent pressure sores. So, instrumented spinal fusion may be performed prophylactically while the curve is still relatively small, meaning less than 70 degrees, and flexible or reactively at the onset of difficulties associated with the deformity. There is little evidence that a prophylactic surgical approach is necessary. A reactive approach may be just as effective when seating modifications are not effective. يعني لما ما فيك, you cannot compensate for this deformity of tilting of the pelvis, you have to resort to surgery. Of course, if the comorbid conditions permit us. The standard surgical intervention is a long instrumented posterior spinal fusion to include the upper thoracic levels to the pelvis. This can be accomplished with unit rods and sublaminar wires in the past, or more with the modern, stronger, but more expensive pedicle screw constructs. The latter, in combination with intraoperative traction, obviates the need for anterior releases for larger curves. The surgical objectives are to level the pelvis, improve the truncal balance, to improve sitting comfort and endurance, and prevent pulmonary problems associated with a large curve. These I have mentioned repeatedly. Please keep this in mind. Why do we do surgery? We do surgery to maintain and improve the truncal balance. We do surgery to prevent pulmonary problems. We do surgery to improve the sitting position. Keep these in mind. Now we finish with cerebral palsy. We come to shorter conditions, which are less boring. But the reason why I went into detail of cerebral palsy is that we see it very often. You have to keep in mind that you have various types. You have the spastic, you have the ataxic, you have the rigid type. You have to pay attention to the type of gait the patient develops. You should create a classification. Is your patient diplegic? Is he hemiplegic? Is he paraplegic? Is he quadriplegic? You have to make a decision. You should look at the mental state of the patient. You should follow the child from birth to later on. When did he sit? Was he late in sitting? Was he late in walking? You have to follow these patients up. You should go into a proper history. Try and elicit a cause. Why did this patient have cerebral palsy? Did the mother have any diseases during pregnancy? Did she sustain any trauma? Did she have any bleeding conditions during delivery? You have to follow up your patients. What about after delivery? Did he sustain any trauma? Did he have any infection which was vague? Did he have any virus infection? You have to look into the history. You have to follow up your patients. Each deformity needs to be followed up, whether in the hip, whether in the knee, whether in the ankle. You should follow up your spinal deformity. See the progression of the curve. Is this patient dynamic? Is he fixed? If you see that he's becoming fixed and less than 70 degrees, don't hesitate to do a fusion on the spine when the cup angle is around 70 degrees. Because you will be helping the patient a lot, but the caregiver might not be happy because the load of the patient on the caregiver, once you fuse them, becomes much more. So you have to pay attention to these patients. Another point, you should observe the gait of these patients. You have to know the types of gait the patient. See them. See whether this patient, parents come, and there are many parents come, they say, we have a problem with our daughter. What's the problem? They cannot put the diaper between the legs. So you have to know. Sure.
سوري
نعم.
دكتور جون معلقة الصورة
ما عادت عم تبين؟
ما بتتحرك على أول صورة بس.
ايه هلا عم بعطيهم ريزومي على cerebral palsy. ما له منينجوسي. هي تجزأت من الcerebral palsy. ما هيك؟ بس ليك
يلا خلص.
عم بعبي لهم راسهم بالcerebral palsy لحتى يروحوا يقروا عنا الليلي لحتى يعرفوا يدلى براسهم. Now مايلومينينجوسيل عم تتحرك هلا؟
ايه دكتور ايه.
Defects of the neural tube occur in approximately 2 to 9 per 1,000 births and are the third most common birth defect in the United States. Bowel and bladder control are affected, and the lower extremity and trunk are involved to varying extents depending on the level of the defect. So it's quite common, between 2 to 9 per 1,000. The goal of orthopedic care for patients with myelomeningocele are correcting and preventing the deformity to maximize mobility and function. So it prevents deformity and maximizes mobility and function of these children. The orthopedic surgeon is one member of the multidisciplinary team, which also includes neurosurgeons, urologists, rehabilitation specialists, physical and occupational therapists, nutritionists, neuropsychologists, orthotists, and social workers. Again, the classification is like that of cerebral palsy. In type 1, you have the child uses a wheelchair and may stand for transfers and may do some stepping supported by another person or using a walker or frame. The second stage of this mobility scale is where the child uses a walker or frame without help from another person. A third stage is where the child uses crutches without help from another person. Or he uses sticks, one or two, without help from another person. 5 is independent on level surfaces. He does not use walking aids or need help from another person. He requires a rail for stairs. يعني بدي يمسك المسكة وهو عم بيطلع الدرج. It uses furniture, wheels, fences, shop fronts for support. And this shows you the description. The orthopedic manifestations. الأسود رجع على الوجه. The orthopedic manifestations by defect level of myelomeningocele. You have to learn this table where whether you have thoracic level, where you have flexed lower extremities, you have the upper lumbar, where you have hip flexion, adduction, partially intact, knee flexion, etc. You have lower lumbar, and you have the sacral. You have to differentiate between these levels on a proper physical examination. Prenatal treatment was done in the past, but was stopped. The surgeon, the obstetrician, or the surgeon, the neurosurgeon, will go in the prenatal through the amnion and do the necessary surgery on the baby. But there were many complications. Prenatal shunting improved motor function, but with increased preterm delivery and uterine dehiscence. Improved motor function was measured as the difference between the neuromotor function level and the anatomic lesion level. The prenatal group was also more likely to be able to walk independently. يعني كانوا ينتفعوا from surgery or treatment prenatally as compared to postnatal. Even though the prenatal group had higher lesion levels, but there were complications. That's why it was stopped or decreased. Other outcomes of interest to orthopedists require longer follow-up periods. Computerized gait analysis is used also here. It has been used in the evaluation of patients with myelomeningocele since the late 1980s. For patients with neurologic involvement of the low lumbar or sacral level, gait analysis has played a role in identifying the deformities affecting function, such as hip and knee contractions, rotational deformities of the femur and tibia, and foot deformities, just as it helped us a lot in cerebral palsy. Computerized gait analysis has a major influence on selection of functional surgical procedures. For example, CGA has helped to identify the importance of hip abductor strength and its effect on gait. Knowing that hip abductor weakness causes excessive pelvic obliquity and rotation has led to the understanding that any surgery that affects the pelvic motion will make gait more difficult. CGA has helped to identify negative effects on gait caused by surgical procedures that decrease the strength of the power generation muscles, iliopsoas, gluteus, and hamstrings. CGA also has been used to evaluate the relationship between energy consumption and gait, using oxygen cost to compare various orthosis and gait patterns. This is the spinal deformity that we have, which is quite similar to that of cerebral palsy. They have severe deformities and require long fusions. Spinal deformity in patients with myelomeningocele may occur as a congenital deformity, resulting from malformation such as hemivertebrae, unsegmented bars. These occur as part of the deformity, the congenital. We know that myelomeningocele is due to a defect in a portion of the spine, leading to dural ectasia and meningoceles. It may occur as an acquired developmental deformity related to the level of neurologic involvement. The incidence of spinal deformity correlates with the neurologic level of involvement. The development of scoliosis in patients with involvement at the low lumbar or sacral levels should alert the care provider to possibility of a tethered spinal cord, because patients with neurologic involvement at these levels have a low incidence of scoliosis. Scoliosis is present in 60 to 90% of patients with myelomeningoceles. Many factors, including functional level of involvement, ambulatory status, level of last intact laminar arch, hip displacement, and lower extremity spasticity, correlates with the development and progression of scoliosis. Gentlemen, don't forget, the scoliosis over here, to correct surgery, in surgery is more difficult than that in cerebral palsy, because the problem is in the posterior arches. Many times in the past, when we wanted to use Luque instrumentation, we could not find lamina to pass the wires around them. But when pedicle screws were brought out, we had it much easier. Many times when we're repairing these cases, we combine both anterior and posterior fusions. The reason why we operate on these patients is to prevent deformity progression, achieve solid fusion, maximize functional independence, increase sitting tolerance, and achieve a level pelvis with a balanced spine. Patients with curved magnitude of less than 20 degrees should be observed with serial radiographs. For patients with curved magnitude greater than 20, brace treatment may be considered. However, the general consensus is that brace treatment does not halt curve progression in this population. A brace may be used only as a holding device. You have to think of this during growth. The brace is prescribed providing that you get the proper fitting and you pay attention very much to the skin. Skin ulceration is a problem. Surgical treatment generally is indicated for progressive curves greater than 50 degrees that interfere with sitting balance. And many times we go both anteriorly and posteriorly to get a better fixation of the spine and decrease the incidence of pseudoarthrosis. Complications include hardware problems in approximately 30% of patients. So you have to pay attention to this. Another problem is you have a kyphotic problem in association with the scoliosis. Many times you have no function below the level of the myelomeningocele where you can do a kyphectomy and get the patient better in a seated position with fusion. And it will help them in standing up. Now, if the child is very young, you have to use a titanium rib growth component, the vector, where you put it and gradually straighten the spine. So you have to be very careful about this. So this is a child who had a myelomeningocele with complete loss of function below that level. A kyphectomy was done, and the child is in a much better seated position. But the problem is they have many complications, infections, etc. You have to pay attention to them. And if you go through this, you'll find out that this child had around 3 or 4 episodes of infection before he was finally cured. Despite the high complication rate, surgical treatment has been shown to achieve lasting correction, improved seating, balance, and resolution. So you have to pay attention to this. So I would say the whole situation repeats itself with hip instability. You have to be able to control it, see at what level does this patient have the myelomeningocele for muscle imbalance, and you should follow the hips as was stated in the past. Now, also, you go through the deformities to correct all deformities. I will not go through this. So enough for myelomeningocele. You can have to pay attention. They can have kyphosis, they have scoliosis, and you can do a kyphectomy for removal of the kyphus. But these patients have a high incidence of complications during the surgery. Now, I'll be honest, nowadays they're giving folic acid to try and prevent these from occurring, but it still not has been abolished. Okay, they have rotational deformities. I want to arrive at the interesting part of these lectures. I think many of these patients are really difficult to treat in cases of myelomeningocele, especially clubfoot, because the skin is very sensitive and they have a high tendency to recur. You have to continuously follow up these patients throughout life. Okay, they usually have an associated congenital vertical talus where you have to treat them. If it's early, you can treat it by soft tissue interposition and pinning of the talus in a more horizontal position to reduce the lateral dislocation of the foot. These are the deformities that one can have. And once this is corrected, you can have a plantigrade foot, but you have to follow them up because recurrence is quite high in myelomeningocele. So in summary, I'll give you the summary of this because it's nice. The orthopedic care of patients with myelomeningocele continues to improve with increased attention to functional outcomes. Ideally, orthopedic care should be administered as part of a multidisciplinary team approach to optimally manage the complex medical comorbidities of these patients. The goal of orthopedic surgeon is to minimize deformity, maximize function and mobility, and limit complications. The take-home message in this case: fetal surgery for myelomeningocele, although associated with serious risks such as preterm delivery and uterine dehiscence, decreases the need for shunts placement and seems to improve lower extremity function in short-term follow-up studies. The most important factor influencing ambulatory potential in patients with myelomeningocele is the neurologic level of involvement. Many factors influence the functional level achieved of patients with myelomeningocele: spasticity, tethered cord, obesity, neurosurgical complications, poor balance, musculoskeletal conditions such as hip contractions, scoliosis. Spinal deformities may develop, including neuromuscular scoliosis, congenital scoliosis, or kyphosis in myelomeningocele. Scoliosis occurs in 50 to 90% of patients with myelomeningocele and may progress depending on the level of the lesion, patient maturity, and curve progression and size. Scoliosis treatments include bracing to offer support, delay fusion, but will not control curve progression. Surgery should achieve good sitting balance, maximize function, and halt curve progression. Spinal fusion may be performed, but the risk of complications in this patient group is very high compared with other types of scoliosis. Patients with poor preoperative nutrition status and positive urine cultures have a high risk for perioperative wound infection. It should be treated before fusion. In a thoracic level lesion and kyphosis, several recent studies have shown that radical kyphectomy and long fusion to the pelvis improve sitting and skin ulcers, but are associated with significant complications. Hip subluxation and dislocation is influenced by the level of the lesion. Controversy exists regarding attempts to reconstruct and relocate the hips. A functional approach to the patient in this situation has been advocated. Gait may depend on hip contractions, then on hip location, and complications associated with surgery, including a decline in strength and increased fracture risk, may outweigh the benefits of reduction. The knees may experience excessive movements that can cause pain or destabilize ambulation. In some cases, bracing the knee with knee ankle foot orthosis offers stabilization. Marked external tibial torsion may play a role in abnormal knee movement, which may require derotational osteotomies. All these are to be considered. Knee extension is also important for standing and should be treated accordingly. Common foot deformities, likewise equinus, equinovarus, and calcaneus deformities, should be treated either conservatively if they are still dynamic or if they're rigid by surgery. This shows you the patients in walking mode. So I would tell you that, again, you have a decreased bone mineral density, just like you have in cerebral palsy, in especially the late stages, and you have to treat them for osteoporosis. These are the fractures that you could have. Even in the spine, they can end up having fractures. Now we come to the interesting part of these lectures. Muscular dystrophy. It is a condition which affects males mainly. Ambulation begins later than 16 to 18 months of age in this condition. In muscular dystrophy, the Duchenne type, they have difficulty in keeping up with the pairs. They have inability to run normally. Ability to jump and hop is unlikely. Unable to climb stairs reciprocally. Positive findings for Gowers maneuver. Cognitive delay. Easily fatigued. Calf enlargement. And they have a positive family history for Duchenne muscular dystrophy or Becker's muscular dystrophy. Let me tell you this, many times we get families who are not acquainted with this condition. They get their son and they say, this child is weaker than his other siblings. If he is on the floor, he cannot get up without using his hands to get up. He cannot go up the stairs easily. And look at his calves. They tell you, look at the calves. They're more enlarged than our other children. Their other children are mostly girls. If you look at the child with Duchenne muscular dystrophy, they have a hypertrophied calf, as is shown in this slide. The most common forms of muscular dystrophy are Duchenne muscular dystrophy and Becker's muscular dystrophy, which are progressive in opposition to cerebral palsy, in which the gene encoding the large cell membrane protein dystrophin is affected. So this is important. I repeat, it's a progressive muscle disease in which the gene encoding the large cell membrane protein dystrophin is affected. So what happens? The cell membrane is destabilized by the abnormal dystrophin. And what does this cause? The cells become permeable to creatine kinase, which can be detected in the blood in elevated levels. The muscle fibers degenerate and are replaced by fibroadipose tissue. Duchenne muscular dystrophy is inherited in an X-linked recessive manner, and 20 to 30% of cases result from spontaneous mutations. The condition occurs in 2 to 3% per 10,000 male births. Patients with Duchenne muscular dystrophy have absolute no dystrophin detectable in muscle cells. Patients typically present between 18 months and 4 years of age with late walking, an abnormal stiff-kneed gait, pseudohypertrophy of the calves, or toe walking occurs, and they may have a positive Gower sign, which I will be discussing. Creatine kinase levels are highly elevated, and muscle biopsy, if needed, shows an absence of dystrophin. This is what I have been speaking about Gower's sign. This is a child who's on the floor. He wants to get up. Look at the way he uses his hands. Then he shifts his hands to the thighs to help the rectus femoris to hold them up stiff. And they cannot stand up straight. And they have considerable lordosis. This is called the Gower's sign. They also cannot go up the stairs. Orthopedic manifestations include muscle weakness. That is greater proximally than distally. They have lumbar lordosis, as I showed you in the slide. They have scoliosis. And scoliosis should be taken seriously because these patients die from pulmonary insufficiency. And with scoliosis, they will have it to much more of an extent. They have joint contractures. Becker's muscular dystrophy may present with more mild weakness than with Duchenne's muscular dystrophy. Elevated levels of creatine kinase, but not as with Duchenne muscular dystrophy. And abnormal dystrophin on muscle biopsy. So Becker's is a muscular dystrophy, but it is much less than Duchenne. They live more. They die at an early stage, but they live more. They do have scoliosis. They have some of the deficiency of Duchenne muscular dystrophy, but less. On muscle biopsy, they have an abnormal level of dystrophy. And this abnormal level is insufficient to prevent the cell membrane from not allowing creatine kinase to enter the cells, to be at increased levels. Historically, patients with Duchenne muscular dystrophy generally stopped ambulating in the early teens and often died in the 20s from respiratory compromise or cardiac disease. Nowadays, we are using corticosteroid treatment has been shown to slow the decrease in muscle strength and the progression of scoliosis. Studies have reported delayed loss of muscle strength, preservation of function, extension of independent ambulation, but at the expense of increased vertebral compression fractures and long bone fractures. These are multiple compression fractures that can occur in these cases. Okay, so you have to be very careful while you follow up these patients. Questions remain regarding whether corticosteroids prevent scoliosis or merely delay its onset, and whether the delayed onset of scoliosis increases the cardiac and respiratory risks associated with posterior spinal fusion and instrumentation. The onset of scoliosis in Duchenne's typically occurs when patients stop ambulating. And the general agreement is that spinal fusion, long spinal fusion, should be performed early when the curve magnitude reaches 35 degrees. Some studies have shown that spinal fusion delays the rate of respiratory decline, whereas others have shown no difference in respiratory change. Families of high-risk patients express satisfaction with posterior spinal fusion and believe surgery improved function and quality of life. Studies of instrumentation constructs show that pedicle screw constructs compare well in curve correction and have lower blood loss and surgical times than Lucey Galveston techniques. This we used to use very often in the past. This is showing you of how we correct them. We use long fusions. We fuse them to the pelvis in these cases. Preoperative assessment should include cardiac and pulmonary function tests to optimize patient condition before surgery. I'm going into detail because you are going to be dealing with these cases. Joint contractures can be addressed non-surgically or surgically to maintain function, assist with seating, and improve comfort. There is a wide variety of treatments depending on the patient's level of function and walking ability, from bracing and stretching to tendon lengthening. This is another condition, which is called spinal muscular atrophy. This is the same patient who was muscular, and what was the result later on. Spinal muscular atrophy is an autosomal recessive disorder caused by a deletion in the SMN1 gene that results in loss of motor neurons in the anterior horn of the spinal cord. This manifests as motor weakness with preserved sensation. Patients present with hypotonia, delayed milestones, and proximal greater than distal muscle weakness. Orthopedic manifestations include scoliosis and hip dysplasia. Confirmation of the diagnosis includes screening for SMN1 deletion. Creatine kinase levels are normal. Remember that in spinal muscular atrophy, creatine kinase levels are normal, while in Duchenne's muscular dystrophy, CK or creatine kinase levels are high. So they are normal in these patients, and an electromyogram shows a motor nerve disorder with normal nerve conduction velocity studies. This is the classification that is used. I'll just go through each one. The SMA gene is classified by the spinal muscular atrophy is classified by the age of onset and function. Type 1, the Wernicke-Hoffman, presents before 6 months of age with hypotonia, swallowing difficulty, and absent deep tendon reflexes. These patients never sit and have significant respiratory difficulty. The type 2 patients have symptoms onset between 6 and 18 months with delayed motor milestones and muscle fasciculations. They gain the ability to sit and have variable walking ability. And type 3 is the Kugelberg-Willander patients, present after 18 months of age and are generally ambulatory, and they have a Trendelenburg gait and muscle fasciculations. The SMA types, or the spinal muscular atrophy types 1 and 2, and in about 1/2 of patients with type 3, they have scoliosis. It usually develops by the age of 10 years, and long C-shaped neuromuscular type curves or thoracolumbar curves are most common. Bracing is ineffective and may result in respiratory compromise. Surgery for scoliosis results in improved sitting balance and endurance. In older children and adolescents, posterior spinal fusion is recommended. In juveniles, posterior spinal fusion to the pelvis may be considered based on a recent study which found that only 36% had major curve progression with the Lukey-Gelfestone fixation. In young children with large curves, a growing rod construct controlled the curves and pelvic obliquity well and promoted thoracic growth with little effect on other thoracic dimensions. This is a patient who has a corset. The tummy is coming out of a hole so as not to cause abdominal pressure. Patients have longer hospital stays but fewer complications compared with patients with other diagnoses treated with growing rods. Hip dislocation is common, especially in severe spinal muscular atrophy, and observation is widely recommended. This shows you scoliosis being treated in this patient. And in a study of 41 patients with severe spinal muscular atrophy, 17 of 82 hips were dislocated and 20 hips were subluxated. 2 patients had pain and 1 had difficulty sitting, prompting the authors to recommend observation only. In one study, hip reconstruction is not recommended in patients with severe spinal muscular atrophy because no pain and no problems with perineal care were found in the study group, and because all 4 of the operated patients had recurrent dislocation. The next is hereditary neuropathy, motor sensory neuropathy, which I consider Charcot-Marie-Tooth disease to be the most important. You see, they have atrophy of the muscles of the leg. They have overactivity of the peroneus longus in this radiograph, while other muscles are weak. You can call them a stork leg appearance, these patients. Of course, they have various deformities, and these various deformities are secondary to 4-foot deformities, and they can be either mobile or fixed. And they have cock-up deformities. Hereditary motor sensory neuropathy is the most common hereditary neuropathy and occurs about 1 in 5,000 people. Multiple forms are described, but the most common is HMSN type 1, which is autosomal dominant, demyelinating type. 1 and 2 are more commonly known as Charcot-Marie-Tooth disease, types 1 and 2. So you have to know this. And this is deformity. Why do they get this deformity? Because of overactivity of the peroneus, the peroneus longus tendon. The peroneus longus tendon. They have also hand deformities secondary to intrinsic weakness. The gene resides in chromosome 22, one should know this, and encodes peripheral myelin protein. The diagnosis is made by family history, examination findings, EMG, nerve conduction velocity studies, and genetic testing. Patients present with intrinsic weakness, foot deformities, ankle sprains and tripping. Orthopedic manifestations include cavovarus foot deformities, scoliosis, and hip dysplasia. Deformities of the foot and ankle are progressive and begin with selective motive weakness of the foot intrinsic muscles. This is followed by weakness of the peroneus brevis and then the tibialis anterior, whereas the peroneus longus and the posterior tibial tendons are still not spared. This pattern of weakness results in a cavus, claw toes, and the hind varus foot. Abnormal stress during ambulation may result in stress fractures, especially along the lateral foot. For skeletally immature feet with early weakness, bracing, night splints, physical therapy, and possible Botox injections may temporarily maintain good foot function. As the deformities continue and cavus progresses, the Coleman block test can be used to evaluate flexibility of the hindfoot. The block placed under the lateral border of the foot removes the influence of fixed plantar flexed first ray, which puts the foot into varus as the forefoot is fully plantigrade. Now, if the calcaneus returns to normal, then the problem is mainly distal, not proximal. The calcaneus is in good shape. The plantar fascia release can be performed in younger children. In older children, an osteotomy along the first ray is added to treat the plantar flexion deformity. Calcaneal osteotomy can be added to treat rigid hindfoot varus, transfers of the tibialis anterior or posterior, possibly medial cuneiform osteotomies, and Achilles lengthening can also be needed to correct the deformity. Triple arthrodesis has its indications, but not without complications. Spine deformities apply as in other conditions and should be fused if progressive. Patients with various types of HMSN were studied. Scoliosis developed in 1/4 of the patients. 3/4 of those with scoliosis had Charcot-Marie-Tooth disease type 1. The deformity rates varied by genotype. Bracing was found to be less successful than in adolescent idiopathic scoliosis. So the surgical indications are similar to those of idiopathic scoliosis, but curve progression may occur if selective short fusion is performed. You have to perform a long fusion. Intraoperative spinal cord monitoring is not possible in most patients, but neurologic injury is uncommon. Hip dysplasia is often asymptomatic until adolescence. It is more commonly noted in alkaptonuria, in Charcot-Marie-Tooth disease, and the radiographs show a shallow acetabulum combined with a proximal femur abnormality. Radiograph evaluation of the hips is recommended on an annual basis. Surgical procedures include osteotomies of the acetabulum. Postoperative nerve palsy is more common because patients with HMSN may be more susceptible to subtle injury. Rigid internal fixation is recommended to minimize immobilization, which may cause severe debilitation. Lastly, Friedreich's ataxia. And it's about time we arrive to it in this long and boring lecture. This is a condition where the patient appears between the ages of 8 and 15. They have walking incoordination. They have arm incoordination. They have decreased hand-eye coordination, speech swallowing difficulties. Diabetes may occur, loss of visual accuracy and hearing loss, scoliosis, heartbeat abnormalities in the majority of patients. You have to know that it's a neurodegenerative disease, most common of the inherited ataxias. The incidence is 1 in 50,000. The carrier frequency is 1 in 60 to 1 in 90 occasions. It's inherited as autosomal recessive, and the clinical features are very similar to what I recently mentioned. And if you look at this slide, it gives you the various types of symptomatology that a patient with Friedreich's ataxia presents with. Friedreich's ataxia is an autosomal recessive disorder that occurs in approximately 1 in 50,000 live births. A defect in the responsible gene or chromosome 9 results in loss of the mitochondrial protein frataxin. Iron accumulates in the mitochondria. Patients present at an age of 11 or 12 years with areflexia, ataxic gait, weakness, and speech difficulties. Orthopedic manifestations include cavo-varus foot deformity, ataxic gait, and scoliosis. Other features include cardiomyopathy and respiratory insufficiency. The disease itself is progressive, with death occurring in the 3rd or 4th decade of life. Scoliosis in 60 to 80% of the patients, and progression is common. The difference between it and the idiopathic is that the thoracic curve is the convex to the left side, while in the idiopathic, it's convex to the right side. Left-sided curves and kyphoscoliosis are noted more frequently than in idiopathic scoliosis. Bracing is poorly tolerated because it may interfere with walking, and its benefit is questionable. This is scoliosis. Outcomes with posterior spine fusion are excellent, but selective short fusion should be avoided. To prevent post-operative progression, intraoperative spinal cord monitoring may be difficult. This is the case. If of various feet that are supple or have significant growth left, may require soft tissue surgery, including Achilles tendon lengthening or transfers of the tibialis anterior or tibialis posterior tendons to achieve good foot position. Triple arthrodesis may be needed in skeletally mature but stiff foot. In summary, and this is the most important part of these lectures, what I'm trying to say is that in cerebral palsy, the central nervous system lesion in cerebral palsy is static, but the peripheral manifestations of cerebral palsy often change over time. Botulinum toxin blocks the presynaptic release of acetylcholine and generally relaxes the muscles into which it is injected for 3 to 6 months. Scoliosis occurs in 50% of patients with quadriplegia and 1% of patients with hemiplegia. The most common causes of intowing in children with cerebral palsy are femoral anteversion and internal tibial torsion, with various foot deformities commonly causing intowing in patients with hemiplegia, but not in patients with diplegia and quadriplegia. Various foot deformities are due to overactivity of the anterior tibialis, posterior tibialis, or both. Dynamic electromyography, EMG, is helpful in distinguishing etiology. Soft tissue transfers alone will not suffice to correct a rigid foot deformity. Bone surgery will be needed in such cases as well. So you can see I've repeated this repeatedly. Please don't forget that the central nervous system is stable. When you go peripherally, they might change secondary to the spasm, the forces, and the deformities that are present in them. Okay, so this is enough for cerebral palsy. What about myelodysplasia? Myelodysplasia, supplementation with folic acid decreases the risk of myelodysplasia, but only if taken in the first weeks following conception. Serial neurologic examination are critical. Changes in strength and or spasticity are early signs of a tethered cord. Prior to kyphectomy surgery, ventriculoperitoneal shunt function must be checked. It should be working so as to relieve the tethered portion or to kyphectomy. If the shunt is not working, tying off the spinal cord at the time of surgery can cause death due to acute hydrocephalus. Hip dislocations in children with myelodysplasia rarely require treatment. Fusion should be avoided during foot surgery to decrease the risk of pressure sores. A child with myelodysplasia who presents with a red-hot swollen leg should be assumed to have a fracture until proven otherwise. So, if you want to do a kyphectomy, you should make sure that the shunt is working. Otherwise, as you ligate the cord while you're doing the kyphectomy, the patient might end up having a severe hydrocephalus and die. What about muscular dystrophies? Pseudohypertrophy of the calf is classic for Duchenne muscular dystrophy, although present in only about 85% of patients. Steroids, when tolerated, slow the progression of Duchenne muscular dystrophy. Unfortunately, they are often poorly tolerated because of their significant side effects. Early posterior instrumented fusion, curves greater than 20 degrees, is recommended in Duchenne muscular dystrophy because 95% of such curves are progressive, and because of progressive cardiopulmonary deterioration as children age. Malignant hyperthermia, this is something very important, as you should warn the anesthesiologist. If you're operating on a patient who has Duchenne muscular dystrophy or Becker's, you have to warn them that they can have malignant hyperthermia, and this is common in children with muscular dystrophy and should be treated with dantrolene. Spinal muscular atrophy, muscle atrophy, the course and prognosis of SMA are directly related to the age at onset. Scoliosis progression is not impacted by the use of thoracolumbar sacral orthosis. Spine fusion may cause an ambulatory child to lose the ability to walk and may cause temporary decrease of upper extremity function because of loss of trunk motion. Hip dislocation rarely requires treatment. Hereditary motor sensory neuropathy, Charcot-Marie-Tooth disease. This is the most common cause of bilateral cavus feet. If foot surgery is required, soft tissue balancing and avoidance of fusions are important. Scoliosis is very common and often does not respond to brace treatment. Neuromuscular disorders in the growing child can result in a wide variety of musculoskeletal pathology. Patients are most effectively managed using a multidisciplinary disorder-based approach that involves the therapist, the orthotist, the developmental pediatricians, physiatrists, and orthopedic and neurosurgeons. Although orthopedic surgery plays an important role in the management of children with these disorders, the evidence-based outcomes of the effectiveness of these interventions remain to be established. Continued clinical and basic science research is still needed to reverse musculoskeletal effects, halt the progression, and improve treatment. So the take-home message. The GMFCS is the gold standard classification for cerebral palsy. The goals of orthopedic interventions for ambulatory CP are to improve gait-related function, gait appearance, prevent or relieve pain, promote independence, and increase physical activities, including sports and recreation. The MOM study, which randomized patients to undergo postnatal repair, was stopped for efficacy of prenatal treatment at 183 of 200 patients. This is the study which was done in patients who were operated in the fetus or at the fetus within the placenta of pregnant women who had myelomeningocele. There were many complications why this procedure had to be stopped. Prenatal repair reduced the need for shunting and improved motor function, but was associated with increased preterm delivery and uterine dehiscence. Good curve control and few postoperative complications were shown in patients with SMA treated with growing rods from the thoracic spine to the pelvis for scoliosis was efficient. Thank you. I hope I didn't bore you.
Thank you very much, bro.
Yeah, Khalid, it is a very boring topic, but I had to repeat and repeat and repeat so that they will never forget.
Thank you very much, yes. And many subjects like TB is very common here in Yemen.
But it's very important, Khalid, that they take them. I know that the audience started as 27 and finally finished at 16. I know that they lost interest at times in this lecture. The reason why it is really a boring topic. I chose these topics because these are not given on a daily basis at universities. Now, the next topic will be metabolic bone disease.
Okay.
I hope it won't be as boring as this. Once we finish with metabolic bone disease, we would have finished with all these diseases which are boring. Then we can go into the clinical cases. Okay?
Okay, thank you very much. Thank you, bro.
Yalla. Have a happy praying period. And don't forget, Khalid, about me.
Yeah, we will not forget you. Thank you very
Yalla,
much.
bye.
Bye.